I am really excited to have Dr. Kerry Shea, an OB GYN who's made a career transition in working with an ADHD coach. But what's pertinent to this podcast is that she also, like many of you listening, is struggling with one of these chronic invisible illnesses, including ADHD. And I got a chance to discover Carrie through an interview she did talking about her life going through ADHD on a different ADHD podcast. But then I got a chance to meet Carrie in person at the International Conference on ADHD, and we could have just had a camera along. It seemed like we talked for well over an hour. And I said, hey, you need to share your story because there's so many people who need to hear it for so many different reasons, including that you are and have been part of the medical community, yet you also now are a patient like many people struggling. So you get a chance to walk the unique line of both working in the medical community, but also now a patient on the other side of things. But without any further introduction, welcome to the podcast.
Thanks for having me. It's a pleasure to be here.
So tell us about your background and kind of your history and share your story to help validate what people have been through, but also to help learn some pearls of wisdom and then moving forward.
Okay. I am originally from Southern California. I currently live in Boulder, Colorado. And excuse me, of course, medical stuff's going to come up now where I'm like, oh, I'm talking about something vulnerable. And in my throat again, but it's literally like, it's just like, oh, this is like vulnerable. So, like,
Yes,
why don't
yes,
we like have a
yes,
physical manifestation of something?
yeah.
I live in Boulder, Colorado. I'm an OB/GYN physician. I was initially sort of ADHD sort of life journey diagnosed relatively early. I'm 52 years old. Diagnosed initially when I was 21 years old while doing a rotation with a pediatric neurologist who said, do you know that you have ADHD? And then I said, I think so. And so for me, all I knew is that like somebody else saw that I was a hot mess. And like that was sort of like my only understanding. And so like I knew I had ADHD throughout, the rest of my life, but I didn't actually learn much about what it really meant until a couple of years ago when I started listening to another podcast, which is the one you heard me on, Kristen Carter's I Have ADHD. And so that sort of listening to that podcast connected a lot of dots for me. And so has helped me transition into my current career, which is an ADHD coach. But in typical ADHD fashion, circling back to went through college, went through medical school, was always really interested in medicine, really loved my job, was able to make things work with my ADHD, but would sort of have just the typical struggles of waiting till deadlines and crashing and just kind of always on the go and kind of always pushing through, which was my personality. And went through medical school, started residency, and kind of had some different variations of like chronic pain issues or sort of just like really random medical issues. Diagnosed with endometriosis during residency, sort of had really bad pain, kind of just pushed through all of that. Um, and in 2012, I was diagnosed with trigeminal neuralgia and ended up pushing through the pain for a year. Was in a really toxic work environment, but ended up having brain surgery for that medical problem. And then was told that I needed to go back to work 4 weeks after my brain surgery or they wouldn't guarantee my job because they didn't have FMLA. So I pushed myself sort of beyond the limit. And then around that time is when my symptoms had gotten significantly better with the surgery, but I started having pain in my neck and my temple. And I think in retrospect now, there was a lot of things of that was my body telling me like, hey, like we're not okay. And in typical me fashion, I just pushed through it and didn't want to disappoint other people and was like really worried about letting anybody else down. So I just went back to work before I was really ready. And for the next 12 years would continue pushing through. Like I would have pain flares that were getting like worse and worse and lasting longer and longer. And I was doing sort of every single thing possible to get better, feel better, like taking care of myself, diet and exercise, body work, massage therapy, acupuncture, all of the different things. Um, and everything just kept getting worse and worse until a year and a half ago, everything was so bad that I actually couldn't get out of bed except for to go to work and see patients. And what I know now is, my body was sort of in complete shutdown because of the continued trigeminal neuralgia, neck spasms. I couldn't turn my head or neck. As the part that you mentioned of like, I think as a physician, I did a really good job listening to patients, being curious, saying, hey, does it make sense? Connecting the dots of, wow, you seem to have a lot of trauma. You seem to have a lot of symptoms. I know these symptoms they're real. Like you're not faking these. These are absolutely true symptoms that you're having in your body. I wonder if something else is going on. And on being on the receiving end as a patient, I was really frustrated because I was trying to navigate, like figuring out there was, some findings on the imaging. There was obviously physical findings of muscle spasms and tightness that would just, no matter what we would do, wouldn't resolve. But I had one really good doctor who was supportive of me, but like in all of the specialists I saw, everyone just threw their hands up and were like, I don't know. I don't know what's wrong. And then, yeah, so just like not being able to see providers who would see outside the box or think outside the box of like what else could be going on. And so ultimately I ended up needing to stop practicing as an OBGYN because I couldn't safely, like if you're doing a delivery or doing surgery, you can't not be able to like, oh, I hope I don't need to get in this position if something happens with the delivery and a baby's coming out or in surgery. And so while I would never have anyone like risk anything with like any harm coming to patients, it just was getting to the point where I was having to hyper focus to like focus on the patient and then completely ignoring my body, and ended up having to stop working a year and a half ago and went out and just spent the next 6 months healing and recovering.
Quick summary of the last 31 years, if I'm doing my math, with trigeminal neuralgia, neck pain. Did you get diagnosed, or did somebody diagnose you with fibromyalgia as well as the trigeminal neuralgia, or more general chronic pains?
So just chronic pain. Never was diagnosed with fibromyalgia.
You mentioned that early in life you were told, I don't know if that was in your 20s, that you had endometriosis.
Yes.
And was that, looking back, the first pain syndrome that you had, or did you have, looking back, problems with painful periods in adolescence or migraines or headaches or any other struggles when you were younger?
And I've been curious about this and meant to ask you not during the session, but I will ask now. I have Raynaud's, and so I don't know if that's something that is associated with any of these things or not. And I'm curious to hear your answer, but that was the first start of things. And then, but yeah, painful periods, which is why I was later diagnosed, would get, yeah, I think I had my first something of trigeminal neuralgia. I distinctly remember it my senior year in college, where there just was like searing, excruciating pain, and I couldn't like figure out what was going on, but then it went away. Mm-hmm. But always had, anytime I would get body work done, people just being like with my body of like, why is everything so shut down? Why is everything locked down?
When you say everything's shut down, meaning have pain and discomfort in multiple areas of your body?
Yes.
And that goes back to your 20s, around this whole time?
I had a workup this is right before going to medical school. I had some like low back, right-sided buttock pain that just was, again, you get imaging. They're like, okay, these are the findings. But there was just, we don't really know what this is. Yeah, I'd broken the tailbone in college. So I think they're like, it's probably just related to that, except for, it happened a year, like breaking your tailbone was acutely incredibly painful and I don't recommend. But this symptom of right-sided pain that was not like really just constantly uncomfortable started a year after. And then it was like, well, it's probably your tailbone. And like, oh, there's, you know, sacralization under L5. So like maybe that's the cause of it. And then I
Yeah.
just remember some dismissive comments from the physician at that time of, I don't think you're going to have a career in gymnastics, which I was like, I don't even know what we're talking about. I don't do gymnastics.
Yeah. Yeah. Why are you talking to that? Isn't that all 14-year-old
Yeah.
5 foot tall people that are jumping into the Olympics? I always like how framing things, the power of words was one of my fun undergrad gen ed classes where how you frame things, what words you use. And I think you said, well, the doctor kind of dismissed, I think was the words, but framing it in a positive way is gave reassurance, essentially. Looks like the bones are in shape. Nothing looks broken. Doesn't look like there's a herniated disc. You're okay, which is on the positive part, and hopefully it'll get better. And that's what often it is. Fortunately, didn't say, oh, you have something wrong. You have a tumor there. You have nothing. As a patient, especially in hindsight, when it continues to be a problem, you're like, wait a minute. Why do I still struggle? And often hearing these stories, people may feel something comes out of nowhere, but often there is a chronic pain syndrome of some kind that is brewing, whether it's painful periods. The interesting connection about Raynaud's, that's a great question. And as a doctor or patient going through this, what is the potential connection? It turns out that all of these are clues. My medical student who works with me this year, he's a first year getting used to taking histories. And there's an acronym that we learned, and there's probably a variations of these, but it's based on a history of present illness of an acute problem, right? It's really designed for an appendicitis, an ovarian cyst rupture, a tubal pregnancy. All of those are the acute event that's relatively tightened time frame. And he did a workup as he's sharing this with his mentor at the medical college of a patient he saw and his experiences and reflections. And he said, yeah, I've learned working with Dr. Lenz, it's really helpful to have a longitudinal history more than just
Mhm.
the acute. And really, I've learned in working because he's listened in and shadowed with patients, 6 afternoons this last first semester of seeing how you can ask questions like we're talking about with you now. Tell me the backstory. And that's part of a chance today. And for many listening who have a backstory, there are other factors that were going on. It's a little bit like the medical mystery. There are clues. With that said, what about the Raynaud's phenomenon clue? Well, we know in a sense Raynaud's phenomenon is where typically the fingers or the whole hand or sometimes the toes and the feet will have a hyper responsive autonomic nervous system clamping down of blood vessels. It's overreacting, and you'll have white, cool, cold hands, and it can be on a continuum, obviously, how strong in reaction, often triggered by relative cold. Another person in the room may think, oh, it's just a little bit cool outside. It's 35 degrees watching a soccer game of some kids playing, and another person is not bothered. And this person gets out of the car, and within a minute, their hands are very cold if they're not taking precautions. In a sense, this autonomic nervous system, the autopilot of our nervous system, is over responsive. And that's where we get into this dysautonomia, which is that bad autonomic nervous system. And what this is occur is I used to think of these as all isolated things. They were unrelated. Oh, this is a discrete illness. Use maybe a calcium channel blocker or something else. By the way, an interesting side note, off label. People have used in women and men Viagra, or the type of medicines that actually vasodilate. So if you have to go somewhere out in the cold, there's an off label use of that actually can be pretty effective. It helps with blood flow, can cause flushing, and temporarily keep your hands cold. So keep that in the back of your mind if that's listening, and obviously talk about this with your doctor. But an interesting side note, well, it turns out a lot of neurodivergent people have a dysautonomia, a hyperprotective sympathetic nervous system overdrive, that fight, flight, freeze mode, which can be if you're trying to shunt blood to your core, that's your body trying to stay warm and safe. The parasympathetic is that rest, digest, relaxation, which many neurodivergent people, especially those who are more on the autistic spectrum, tend to have a tilt in that direction. By itself gives me a clue. And when I start to hear if somebody has other chronic pain syndromes, and then if I do ask some probing questions about autistic traits, and as more may become evident, it might be, oh, that might be a trait, a physiological manifestation of a dysautonomic nervous system. And we have things like POTS, postural orthostatic tachycardia syndrome, where people will have imbalance in controlling of blood pressure with prolonged standing, sense of lightheadedness, and all of these overlapping. I don't know. What are your thoughts on that? Answer to that? Or
Yeah. Oh no, I do. I think it's funny because when you talk about like long-term medical stuff, like this is something that pops into my brain. But the reason that it's at the front of my brain is I was working with one of my physician ADHD coaching clients 2 days ago, and she just held up her fingers and she was like, Myra nods, like her fingers were completely white. And I was like, I held up my foot and I was like, I don't have any blood in this toe.
for all of you who are listening now who have Raynaud's or have a history of Raynaud's, you can share in your comments if that's been part of your chronic pain journey and neurodivergent journey. And if you also want to add, if you have been diagnosed as being neurodivergent in some way, or if you haven't, suspect you have, or added to that if you have any relatives who've been diagnosed. It's not uncommon where a niece or a nephew or son or daughter may have been diagnosed. So the interesting thing, and this is a question when I was listening to share, and part of why your mission now after transitioning in your career is, what education, coaching did you get at age 21 about ADHD? And what would you, if you could, tell your 21-year-old self?
I mean, at that time, so I was working with a pediatric neurologist, and who specializes in autism. I was doing research in her lab before medical school, and so she just said that if you have ADHD, do you know about it? And then that was sort of it. And then somehow I got connected with a physician who like prescribed medication, but then I never like wouldn't. If there was so many barriers to like getting medication, then I like would just randomly get used medication when like things would get bad, or I would like everything come crashing down. So like nothing. There's no discussion of what does this mean. And again, as I said, like what I just internalized was that like people saw like that I was like in my mind, like they're like, oh my gosh, she's a disaster or something. Like that's sort of what I was like, oh my God, other people can see it too. How embarrassing. But nothing after that until I started doing my own, like listening to other books. Cause also a lot of the books I think about ADHD are incredibly ADHD unfriendly. Like I don't need a list of a million times, like get to the point. Starting to read more books. I know Tamara Rosier has been on your podcast a couple of times. Like her book is just one of my favorites, the Kristen Carter ADHD podcast. And so as I started learning more about ADHD and everything started clicking in my mind, I think what it would have been helpful at that point, which is what I do with my clients now, is saying what we do makes sense. A lot of the times, like my clients will say, I don't understand why I do this. Like I always do it this way. And I was like, but what if it makes sense why you're doing it that way? Instead of, hey, I'm not doing it the way that, like, do it what works for you. What we're doing it makes sense. We're doing it for a reason. And it doesn't have to it makes sense to us. And it also makes sense to other people who have ADHD. Doesn't have to make sense to everybody else. And so I think that that's something that like me hearing that for younger self would have been really helpful. And also just what I do now with clients is work and explain that, and also understand like how like our nervous systems work, why again, everything also makes sense. Like the things that we avoid make sense from a nervous system perspective. Like our brains are so like I know everyone has different brains with ADHD, and there's fast processors and slower processors that tend to be a great fast processor. And so I bypass feeling a lot of sensations in my body. But what's happening is I'm skipping over I don't want to do this because it makes me like sending this email feels like there's a tiger in the room. And there's not an actual tiger in the room, but my nervous system doesn't know the difference. And so I think a lifelong exposure of tigers in the room for situations where there's not a tiger in the room resulted in a lot of my chronic pain and a lot of my symptoms, and also, again, just a real twitchy nervous system. And so understanding that and slowing down when it gets to stuff that I'm avoiding or stuff that I'm doing to really then be like, okay, how do I like reassure myself that I'm safe? How do I actually reassure myself that like this phone call is not a tiger?
What I'm hearing is you experience that, and if I could speak for you, that early messaging was the stereotypical messaging. You have externalized your symptoms. You're a spaz. You have ADHD. If you want to be a doctor, get it together. I know somebody. And I'm guessing your thought process was, if I can just mask, which you didn't know the term, but if I can mask well enough, and then at times, if I just can augment medication for intense studying, for exams, et cetera, I can use it for that. And unfortunately, it is a hassle because you have to call every month to get the medication, which maybe you didn't know. And it's a little more sophisticated. And maybe even back then, probably back then, you actually literally had to go to the office to pick up a prescription. And then likely a little stigmatized, like you're getting methadone or Oxycontin, like you're a druggie in sense, and so that probably maybe added some stigma.
Yeah, and I think also prior to the diagnosis, because because I'm 52, that in the 70s and 80s, like only boys had ADHD. It's not true, but that's what they
Yeah.
thought. And so I was in the gifted and talented program, but then constantly got messaging of like, what is wrong with you? Why are you like, you're not trying, you're not applying yourself, you're not doing any of the things. And I mean, luckily for me, the idea to become a doctor was my idea. It was always like something that like I loved that. And throughout the time, I was told a lot of times, like, we're not going to recommend you for this class, like gifted and talented class, not because you can't do it, because you're lazy and you're not doing it. And so it wasn't this is an ADHD thing. This is like, you're not applying yourself. So, like, there has been that negative messaging, but luckily I was passionate enough about medicine and interested enough to be like, I don't understand what's happening. I'm okay. I don't care, but I just moved forward in doing it. And one thing I didn't mention, I'm a single mom of an 8-year-old boy who, being a parent to him and seeing, I don't know if he has ADHD or not, but just seeing how the schools are navigating things, at least in my area, differently of, hey, this kid's struggling with this. What do we need to do to support him? Like I cry at the first parent teacher conferences for the first couple of years, just because I was like, I mean, if we were treating people who were just struggling, not with you're doing this on purpose, you're doing this because you're bad. Like I see how hard you're trying, like, but I don't understand what's going on. Just how much like everyone deserves that kindness and that support. Obviously, not everyone gets it. So I'm incredibly grateful that we have it for him. But I'm sure many other people who are listening who've experienced this have the same journey of being blamed for stuff. And it's not a character flaw, it's not a intentional thing. Like we're just doing the best we can and didn't know what I didn't like. I didn't know I was doing the things and we're not doing the things.
Yeah, and all of these interconnect, and you're right. And we talk about ADHD on this podcast a lot. On the women special interest for girls and women with ADHD. It's been naturally something I've been aware of because in the chronic pain world, maybe 70% of people with chronic pain syndromes are female. And men are often missed in the chronic pain world because they are too stoic to come in as well. So it's sometimes 90 to 10, but reality, it's probably 60, 70 to 30, 40. And often struggle with this as well. The higher your IQ, oh, you should be able to figure it out. I had share a story of a family where the two brothers came in and they were diagnosed with ADHD. I was their doctor, but they were seeing a girl pediatrician because I'm a pediatrician and an internist, a female pediatrician. And the sister's like, and said, "Oh, I'm pretty sure I have this." And the pediatrician said, "Oh, you're getting A's. You can't have ADHD." And
Yep.
and I said, "No, that's actually," as I had Dr. Skoglund on, who's from Sweden, and she's like, "I have an MD, I have a PhD, I have ADHD." So often that misunderstanding. But what we're finding is this overlap with chronic pain is high. It's like 70 to 80% of people with chronic pain syndromes. And the more severe you have, the more struggle you're going to have. And we just had this week of this recording a interview with a woman in her 50s who has trigeminal neuralgia, and she's a warrior trying to battle. The interesting thing is, she said in the interview, um, Marcia is her name. She said, "I did the testing of ADHD," and I said, "Oh, what are you taking?" And she's like, "Well, I went to the psychiatrist, and the psychiatrist said, 'Oh, no, you don't have ADHD. You have anxiety and depression.'" And I said, "Wait, you had the testing?" "No, I did the online testing, and it clearly show I had this." And I'm like, "Oh." And then we started talking about this high comorbidity and a lot of these things going back in time, some of those struggles. And then hormones probably play a role as she started having these problems, as she recognized trigeminal neuralgia is often in the perimenopause to menopause, postmenopause time frame. So there's probably an overlap as we're learning more about neurodivergence and susceptibility and autoimmune kind of things. We know autoimmune illnesses, like of all different types, have higher rates in neurodivergent people.
I have hypothyroidism, so
Yeah,
that
and
d-
you add that to the
diagnosed, yeah, at like 40. Yeah.
you add Raynaud's, you add some of these hyper responsive things. And like you say, oh, these aren't always maladaptive ways of coping. These are different strategies that often can work. But as they say in the world of ADHD, at what cost, the amount of extra brain power to do everything. I just talked to a physician this week who I'm seeing her partner, and the partner is getting treated for ADHD and knows I do this, and similar to your story, was diagnosed early in the career but not consistently really taking meds. Kind of took it to get through med school and kind of get through residency and sort of took a break, but now is not getting the charts done as
Yeah.
consistently, except has a bottle of Adderall left over from 2019 that she's just got this little leftover. And she's like, "Well, I took one yesterday." And then one of my colleagues like, "Wow, you're really getting your charts done." You know,
Yeah.
and that all adds up to the struggle that goes along with it and the pain. The podcast called Conquering Your Fibromyalgia, because my hope is that people can improve, can get better, but not everybody does, and they have to, unfortunately, go on disability. Can you talk about the years leading up to going on disability from work? You had put so much work into going through pre-med, going through med school, going through residency.
Yeah, and I loved my job. OB is just like, it's diverse. You get to help people. It's mostly healthy people. I don't deal so well with like sadness, but like you get to use your hands, you get to use your brain. Like it, it was just, there were so many things I loved, but it was also an incredibly stressful. It's an incredibly physical job. And, as I said, for the 12 years after my surgery, I had pain all of it, like every day, but I would have pain. It was sort of just like a constant low grade background stuff. And then I would have periods of time where I would be up in the middle of the night, like messaging my doctor, being like, "We have to try something else. Like, I don't understand what's happening." Like, again, just an excruciating pain. And it sort of would progressively, as I said, over like the last couple of years, build up and up to like weeks. I get Botox injections, which help. I was doing all the physical therapy, doing everything, massage, all the stuff that I could do. And it would just get debilitating to the point where like I really couldn't function on days that I didn't have to work. And like at the end, when I was talking about, like, I was talking with my neurologist and we're trying to figure out, like, I'm like, I don't want to take too much stuff off my plate because I don't want to like bother, like make my partners like add too much to their plate. And she was like, we have to do something bigger because like the little steps isn't going to do enough. But also, like, at the end, they were asking me, like, well, why didn't you like take time off? And I was like, taking a day off didn't make any difference. Like, this has been something that's been getting worse and worse and worse and excruciating and debilitating over, the last 12 years. And so one day off isn't going to change anything. A week off wouldn't change anything. It's sort of like one of those things of like putting, and don't do this. You shouldn't put any animals in like boiling water. Just want to be super clear. But it's
not tell.
I just felt really weird about saying that. But like the metaphor of if somebody had thrown me into this, like I had been minding my own business and this had happened out of the blue, then he would be like, what the hell's happening? This is so terrible. But each day, like over 12 years, progressively sort of going uphill, 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 you're like, but this is horrendous. But it's no different than yesterday. And I made it through yesterday. So like, why would I stop today? Because it's not going to get any better. And I don't know what to do to make it stop. And so luckily, at least my neurologist was amazing. And there was so much also fear on my part about what if other people don't believe me? Because I don't necessarily mask my ADHD very well. Like I can hyper focus, but like I just am like, I have big personality and I do all of this stuff. And I would do this with patients, which like my patients loved me. So not all of them, but most of them did. And so, but I masked my pain really well. And so I was like, but how would you know? Like, I was like, but what if somebody doesn't believe me? And then it was funny because I became a certified coach in 2016 to learn how to deal with my super toxic work environment. And then in typical ADHD, super curious person fashion, have done like 4 additional training programs. Then I started doing ADHD coaching, trauma-informed stuff, and then psychedelic facilitation for healing and more ADHD training. So like it's been sort of a compilation of all of the things. But I was working with a client and I said something to her once about like, she was talking about something completely different. And I was like, but if somebody doesn't believe you and it is true, does that make it not true? And I was like, why am I like so fixated on if somebody just didn't believe me about the pain? That's okay. If it made the pain go away, then that would be fine. But they don't have to believe me. Like, I am not faking anything. Everyone's going to have their own opinion about what's going on. But I was so fixated on whether or not I was giving up too early and also whether or not other people would believe me. And it was doing that at the cost of myself and then getting more and more dysregulated, getting more and more exacerbation of pain because it's a form of fight or flight hypervigilance that wasn't like, but my neurologist was like, okay, we need to, again, like we need to do something serious because like you can't move your neck and like this just it's not good for you. And there was at least one part of the HR experience where she's like, because I was like, I'm going to keep going to work. And she's like, if you're spending all of your time and money out of work to be able to be functional enough to come to work, like that's actually not appropriate and that's not healthy. And also from a liability perspective, like if something did happen and like somebody knew that I was having pain, then like they were just like, okay, we need to stop. And so I went out on work with the plan of doing every single thing I could to go back to work. And once I was out and then able to sleep and heal, and I still, again, it's a year and a half out, I still will have symptoms a lot of the times. I still have days where I can't function. I still have pain flares. I am aware that like going back, once I got out of like the rat race and that like, I have to, what other people are going to think. I actually was like, it is not okay what was happening. There was just disability was the right thing. And even like sometimes my brain goes to like, well, should I try to go back? And I'm like, if I like hold my neck in the wrong position for too long, everything will still spasm sometimes. And I'm like, I can't operate. I can't do 8-hour days. Like And I have what's called own occupation disability, which is why I'm able to do my coaching stuff, because that's really healing for me. And I'm not wired to just sit at home and do nothing. Like some people, I know that's not a judgment on anybody else, but like I like connecting, like it's healing. I'm loving being like more present as a mom and doing the things. But so I do a certain amount of coaching a week. I'm doing learning, I'm doing reading, I'm continuing my healing, I'm trying to do all of the things. And if some capacity, then I go back to medicine. But it's just physically is not something that I can do.
Yeah.
That's a long answer.
I think it is likely relates to a lot of people that are going through this. There can be this engine grinding going up the steep mountains of Colorado, and you can go a little bit and it's a steep hill and you got a little 4-cylinder that's powering a trailer, pulling something, and you add some more stuff on the trailer. You can turn up the radio. You don't hear the engine grinding as loud. And that's kind of masking. And eventually the heat goes up and
Yeah.
it starts the grind, and turning up the radio really loud is the metaphor of doing all of this other stuff. Eventually you're like, if I pull the car over for 5 minutes to let it cool, I still got to keep getting back on the road to go up this mountain. So as long as there's a mountain to go up, I don't know if this is a sustainable.
Yeah. Yeah, it's yeah. I like that, like you're blasting the radio. There's nothing to see here. This is like totally fine. And you're like, the engine's on fire, and you're like,
It's smoking.
things are not fine.
And of course, sometimes it's just not even smoking yet. On the outside, people don't see it. And if you don't share that, they may not even recognize the struggles that you have, that you're going through. And it is hard. And unfortunately, I have a cognitive job where I don't do procedures anymore. I had training as an internist to put central lines in and do procedures. Now everything's compartmentalized, hospitalists, and even with doing shoulder injections and stuff, which is nothing like delivering a baby and all of that. So now I get a chance to basically do what you're doing, coaching and talking. But when you're doing a specialty where you're expected to be at deliveries and do C-sections and do hysterectomies, is just part of that. It's hard to just say, well, just do that. There isn't a practice. It's like being an orthopedic surgeon who says, I can't do surgery anymore. And they could work at the walk-in urgent clinic to diagnose the broken bone, but they're not doing the surgery. They're essentially not doing their full potential.
Yeah. And there are like even clinic with OB is actually a much more physical job than people have any idea. So doing biopsies and trying to look in cervixes and all of those things, like there's a lot of contortion that happens
Yeah. Yeah.
in that, and checking cervixes and like bundle, like it's a very physical job.
Yeah.
Yeah.
Yeah. So for all of you who are in pre-med or med school right now and you're not decided yet, just take this as a grain of salt.
So fun though. I
that is-
really do love
And it is a neat part. I think that's the nice part when you're looking at all of these things. From usually there's good prognoses. People have good outcomes with deliveries, and it's nice to see. As I used to say, I started my day working in the hospital years ago before hospitalist, but I started in the ICU, go to med surge, go to peds, and then finish in newborn nursery, because it's almost all the time was sharing happy things, what to expect, how to feed a happy, healthy newborn, which most of the time, speaking of newborns, and I share this and I've talked about on the podcast, but the first syndrome, if you want to call it, of a chronic pain is colic. Did you know that?
I know that because of you.
Okay,
When we
so
we talked at the conference.
Yeah, or listening to the podcast here, which is one of these early recognitions, like, hey, keep an eye on this, because there may be some issues with constipation or stomach pain or migraines and IBS symptoms early on, and recognizing this. We got a chance to talk about this at the conference. I'm not your doctor, but we were just talking a little bit more like doctor to doctor and trying to offer some insights. And you had talked about some restless leg, periodic limb disorder symptoms. And you talked about in putting this in the power words, the most neutral, selectively taking your ADHD medicine or inconsistently taking your ADHD medicine.
Oh, yeah.
So, can you talk about those and maybe some insights you've learned about that and the impact it has on some of your quality of life and functioning?
Taking the medicine?
Yeah, the impact, I guess, one, I think you had relayed some symptoms of restless leg type symptoms, variable
Yes.
mood disorder. And I don't know if you were diagnosed. I just mentioned that in passing, and I don't know if you had been diagnosed or not.
Yeah, and I did, and it's so funny. And I'm thinking, and I'm like, I have some ADHD meds right here, and by my left hand, I'm like, I have not. I took them yesterday. I didn't take them today. It's maybe why my my answers are a lot longer than they probably need to be. But yeah, no, and I do have a history of restless leg stuff. I previously gotten a ferritin check. I got my iron infusions and things immediately went away. And so when I was having in the months before we talked, like I was having like this jerking myself awake in a not necessarily in the typical like creepy crawly thing, but like just crazy making. And so I started with like, okay, I'm gonna check my thyroid again. I'm gonna check my iron studies and my ferritin. My ferritin's like above normal now. And I'm like, so I did talk about like I did get a prescription for gabapentin, which I take intermittently. Um, because my symptoms are intermittent. And so I think it's one of those I had taken gabapentin before in the past for the trigeminal neuralgia. And I think I told you the story of I think a patient I just remember being so groggy and like, and I was like looking at a patient and I was like, I don't know why she keeps talking to me. And I'm like, oh, this is probably not the medicine for me. I don't have symptoms consistently enough, but I think this is a good reminder to be like, okay, I should, when it seems to go cyclically, and I don't necessarily notice a correlation between pain flares or not. I think that's one of the things that's so hard in my journey of things of there are some times where like when I got back from the ADHD conference, like I allowed for 2 days for myself because I just was like, in case I crash, I need to be able to relax and like really not have to do anything to push. And that's sort of the benefit of like all of this. And I did, like, I came home and I like had 2 days of like not being able to like do anything other than get my kid out of the door and then come back and like rest.
Yeah.
And then there are things where I can do that exacerbate my symptoms.
Mhm.
And then there are the times where it's just out of the blue and I think that everything's fine. And so the sleep is, I think for me, if I was having restless leg symptoms all of the time, then taking the medication, like I'm not anti-medication. I just sometimes forget. And then if I've forgotten to take it too late at night, then I don't want to be a zombie in the morning.
Yeah.
But if I had consistent symptoms, then I'm like, this of course would make sense to take every night. And so I get into this, yeah, weird pattern of take it or not.
Yeah. And one of the interesting clinical pearls about restless leg is one is that restless leg is that initially hard to fall asleep, feels tight, creepy, crawly, an urge to move, and it feels better when we move. Some people will have, while there's most people when they are sleeping will have movements, which might be twitchy or movement or tossing and turning. If somebody's sharing a bed with a partner, they may notice that they move around or kick in bed. Often you hear the story of many patients, about 20 to 30% had this in childhood, and they recall sharing a bed on a sleepover, a friend or cousin or family member who said they couldn't sleep with them because they were kicking a lot or they were moving too much and it was annoying. I don't know if you're
I'm
smiling.
I'm laughing at one of my best friends from elementary school. I used to terrorize her with randomly raising my arm. And so I would just like she would wake up and look over and my arm would be like either raised up or I would be doing this with my arm. Like, and I did it my entire childhood. I still do it now occasionally. And it's just one of those things of it's not twitching, but it is just and I've seen other things people talking about this with neurodivergent of like again, in addition to I would sleep for a long time with like the sort of T-Rex arm, but I've moved away from that because I was getting like ulnar, like bilateral ulnar like radiculopathy and things like that. And so I like work on that, but I still will sometimes wake up with my arm raised in the air. I'm like,
one of the things, if somebody is not feeling rested in the morning, especially if you're not sharing a bed with somebody, if you're not feeling rested, you may be moving, you don't notice it to some degree, and maybe that taking it a couple hours before bed. One of the things that I often hear in people with their history with a gabapentinoid, which is the pregabalin Lyrica, brand name Lyrica, or gabapentin brand name Neurontin, is, oh, I tried that. I didn't like it. I gained weight. I was a zombie. And usually what happens for people who are unaware of the restless leg component or periodic limb component is they took it in the morning, they took it in the afternoon. Somebody complained of pain. They kept ratcheting up the dose until somebody has intolerable brain fog and confusion, gained weight, and then they do, oh, I couldn't tolerate it. Well, it causes, and actually it's a bad thing if you already have, and most people have unrecognized ADHD with this, so they're not taking a stimulant. Now they're making something that impairs them cognitively during the day. And instead going, well, let's just focus on getting good sleep. And at the core of chronic pain, fibromyalgia, overlapping pain syndromes is having to get consistent good sleep. Now, a clinical pearl is, but just a simple activity counter, watch, etc., that can track your steps. But many patients, if they hit a minimum threshold of steps during the day, they quote wear out their legs and they don't need anything for their restless leg. And a lot of people, and I had a patient that shared this story. She was in high school, had restless leg, treating it. She was getting about 8,000 steps. And then she got a job as a nurse's aide, getting about 25,000 steps a day, just walking around, carrying, being on your feet all day without any quote exercise intentionally. And she's like, I don't need it anymore because I sleep fine. So sometimes there can be, oh, you know what? When I got a chance to go with your son or daughter or whatever to the park, and we had some outdoor fun, and I didn't seem like it was quote exercise, but oh, and then I went to the store and I got 12,000 steps. Oh, I slept better on those days, and I did it a couple days in a row. Maybe it was cold, you didn't get a chance to do stuff. Maybe you had the boom bust cycle, you were doing good, you did a lot, and then you overdid it, and then you busted. So tracking that can affect it. And the other interesting thing about the iron deficiency, we check for that, and that can be a case. And sometimes, that has to be repleted with iron infusions. But at 52, probably have gone through menopause. So probably not losing blood in the typical way. As another clinical anecdote, I had a woman who was in her mid 70s who came in just sharing that she had these restless leg symptoms in a roundabout way. And most people who've had this, it's normalized. They're like, "Do you like?" And I said, "Well, surely you've had these for years." She's like, "No, they just started 3 weeks ago." And I'm like, "Really? Okay." Well, it turned out she had a bleeding ulcer and she was lost half her blood volume, having her go emergently to the emergency room and get a blood transfusion. So when she came in a year later with the exact same symptoms, I'm like, "Yeah, you look pale. Look at the conjunctiva; they're pale too. Is your stomach bothering you?" "Yeah, it's kind of achy." I'm like, "Yeah, I'm sending you right over to the hospital." Those are always things in the whole world of chronic pain that you have to be looking for co-occurring illnesses or conditions that can affect it. The other fascinating thing is it's the environment. Is we There's a weird condition that occurs in many neurodivergent people. It's called idiopathic urticaria.
Yes.
Unknown itchy rashes. It comes out of nowhere. And I've always been interested in unknown things. This is a channel for mystery illnesses. If you have invisible mystery illnesses, and as one of my nurses who's discovered me that you're really good at patients who fall through the cracks where the other doctors can't figure it out, but you're able to connect these dots, many of whom are neurodivergent. So the story of idiopathic urticaria, I remember as a medical resident working for a month in allergy, and they're like, we just don't know. Something happens, and it's probably not their laundry detergent, right? It's nothing obvious in the environment. But now when you look at it from a neurodivergent perspective, oh, this is a crescendoing. They may be autistic. They've been having sensory overload, work overload, and it hits a tipping point. So a recent patient of mine is in executive in charge of projects, project management, working 14 hours and there's budgets. Sometimes you're working past midnight. And she does have her ADHD treated now, and she's taking it, but and oh, by the way, on top of that, let's add Christmas, all of this on top of the regular stuff. So there's a wedding being planned, and she has these itchy rash popping up. And her sister's a doctor, and her sister's like, I got a feeling it's stress. And she knows me and she knows I understand complicated stuff. So if a doctor said, "Oh, it's just stress," many would be a little dismissive. But her sister said, "Yeah, I had this man who had these idiopathic urticaria, and we couldn't really get on top of it and figured it out. But finally went away when he retired and moved to Colorado."
Right, not the altitude. Was that was not the change that made it
But
happen.
whatever big city, I don't know where, but
Yeah.
but it was obviously the work stress, the outdoors, like the awesome about Colorado is the nice big outdoors, the hiking, those adventures and the big openness if you're not in the big city of downtown Denver. But that's the recognition of this environment and the challenges. And it's not always easy to measure like a thermometer, the environmental stress, the just part of the nature, like you say, I think you were referring before, like a frog, and you turn up the heat slowly, it doesn't jump out, right? And the heat was getting turned up slowly over time on you, and it's hard to perceive that. And then also, if you look around, going, well, everybody else is in the same temperature water as me, I don't think I have the bad luck that I keep getting hit with the worst calls, with the worst patients. Over time, it's average. But that's also getting into that sensory sensitivity with pain and others who will have the same amount of pressure, exposure, and will report more distress where another one can't. And then that's the battle as you go through this, not adding more rejection sensitivity, that I'm a failure, that I can't do this, but just know we have different brains, they work differently. And I would say to somebody like I'm seeing like you, if I saw you, if I see 21-year-old versions of you is talking about the role of educating and learning about things. I just saw a 24-year-old woman today who I saw a month and a half ago with severe fibromyalgia, IBS, migraines, restless leg, ADHD, and had enough of these autistic traits on initial probing where she read the book, "Is this autism?" Did the CATQ, the RADS, and she's like, "Yep, that explains me." We've dialed in her pregabalin. We're starting to treat her ADHD and starting to do some healthy lifestyle things too. And her score is markedly improved. And having that early awareness back in the late 90s when you were going through this, there wasn't how to ADHD podcasts, books to talk about this. There wasn't even books on women getting ADHD hardly if you're talking mid 90s. It wasn't really until the early 2000s. So I think awareness, and as I like to share, as I talked about at the conference, is it's nice when I can even recognize that 8-year-old boy or girl who might otherwise fall through the cracks. As I shared one of the studies out of Sweden, when they were looking at the kids who, the middle school, young women who were then followed 16 to 19 years later, who had a diagnosis when they were younger of ADHD, autism, or both. And those who were continuing on ADHD medicine had about a 16% rate of chronic pain versus about 45 who weren't on medication. So it's a tool in the toolbox, but also in trying to look at the challenges in the career. How can we help with accommodations and planning, and then avoid some of the challenges and the trauma that now you're trying to get through, right? You're trying to dig out of a lot of this.
It's great. No, and I did think of, I will say, a non-specified family member who came in town for Christmas, who doesn't do a lot of traveling because gets overwhelmed. It's got eczema, like just an eczema flare within a day of arriving. But I was like, I think the connection that, like, hey, I'm like maybe the more stereotypical ADHD person in my family, where we're like, oh, maybe there's some more. I mean, there are, but I'm not gonna speak on that further with Rich again, because that's their story. But like, I think the other thing is when I'm talking about like how you discuss stuff with patients, like I think that I had a new client call last week for a coaching, or earlier this week for a coaching call, who similar has ADHD, but a lot of these physical symptoms. And I think the nuanced way of actually talking about it with clients, I start with not in a like, let's make this about me way, but I think sometimes if I actually talk about my journey in a slightly more succinct way about the pain is real. I'm not saying that this is in your mind. I'm not saying any of these things. Like it allows for a softening with them actually. If I just go in and approach and being like, I think this is stress and trauma and nervous system stuff, and these symptoms are causing these things, like I have found that I get a lot more people sort of melting in relief or actually being seen and understood, that I'm not just a doctor dismissing them saying this is just stress. Because it is stress, but it is like, let me tell you, like, this has significantly impacted my life in these ways. But also, there is, I believe, hope for you if we actually understand, like, first of all, understand why we do what we do, but also understand that sometimes these symptoms, like I was thinking also, like I got pancreatitis for no reason one time. Like I don't drink very much. Like I just got pancreatitis. And everyone was like, they don't know why you got it. And I'm like, can we like maybe dive into that further? And everyone's, it doesn't make any sense, but you just got it. And I'm like, that's unsatisfying. But like now through the lens of some of this, like where you're like, weird stuff just happens, and so, like, understanding why the approaches of, I think the more we understand, like, why we do what we do, regulate nervous system, do self care, and do all of these things. Like, I know that my clients are most of my clients, I have a lot of physicians as clients in my coaching who come to me about like charts, but really when we start working on how we approach things, it's like applicable across like everything. But the amount of my clients who, oh, I have this neck pain, it's unrelated, it's just whatever, or I have this back pain, it's just structural. And so then we start incorporating like, hey, the more we work on I'm also doing some, of course, certification in neuroplastic pain, chronic pain reprocessing, which is like teaching yourself that these symptoms, like if there isn't, first of all, you have to do an appropriate workup to make sure that we're not missing something like restless leg and you have a bleeding ulcer. Like, no, we don't want to just jump to, oh, this is neuroplastic. But when you've had appropriate workups and being like, okay, the worst thing for this is being like, there's a problem, there's a problem, there's a problem, emergency. Like sometimes it just is reassurance that things are okay, you are safe. And that is amazing how that can melt a lot of the pain symptoms or fatigue. But it has to be done in a way that is nuanced.
Yeah. And I think that mindset of understanding that neuroplastic, the brain can adapt and change like we learn language. Nociplastic is kind of the umbrella term we use for chronic pain syndromes. And often there's both a neuropathic, an injury, like in your case, trigeminal neuralgia, and you can develop these nociplastic overlapping syndromes that occur with it. And I think when the word is it's all stress, it implies, I think, a pejorative kind of term that, you need to get it together. You got to handle this. And that's also kind of a critical analysis. And if many people, as you're working with those with ADHD, have rejection sensitive dysphoria, have emotional hyperarousal, that term is pejorative, is cutting to that person. And that's what I hope in you getting a chance to share your story, that even doctors go through this. Doctors have challenges. You've been on both sides. You can recognize that doctors are not immune to this. Some might even say there's higher rates of neurodivergence, for example, in doctors, because often they're very smart, but often get at the burning point. One comment, or just, I should say, thought for you, as you've done a lot of deep diving with this, there's more recognition of physician burnout. And
Right.
that's a term that you and I are pretty close in years, 54, you're 52, but obviously wasn't really talked about too much in the 90s, but it's getting more recognition. What portion of physician burnout may a neurodivergency play a role in that, as much as environmental factors? How much do you think there may be some of what we're calling that is people who also are struggling with an ADHD or autistic style brain or nervous system, and that's contributing to their challenges.
Well, I mean, my brain's gonna be like, what is that word? But like, I mean, my vantage point is like it's most of everyone who I work with. So like it's gonna be like all of them. But I mean, I know, I mean, I mean, the medical system, it's broken. So I think just at baseline, when you're adding in like the finances of medicine, the expectations of what's happening, the liability situation, like my chart messages, sending messages, like a lot, the amount of unpaid work, like I think everyone is sort of just frustrating and drowning and like art doesn't necessarily like this is not why a lot of people went into medicine.
Mhm.
So I think inherently across the board, people in medicine are struggling. And then when you add on top of that, like neurodivergence, you're adding like you're doing things on hard mode. And I think physicians with neurodivergence like make outstanding physicians. And a lot of the time, like at least when I talk with my clients, they're the same thing on me. And there's people who went into medicine for their own reasons and just don't really love it or wouldn't do it again. My clients are fascinated by medicine. They love medicine. They love doing the deep dives into everything. But I think a lot of that thing of that wiring that happens of like the divergent thinking of like, okay, we could do it this way, we could do that, like all of the different 40 chess. When you're applying 40 chess to figuring out a complicated medical problem, then that is a great useful tool to have. When you are applying it to where do I start my in basket, when you're applying it to every single thing in your life all of the time, it is exhausting. And so, coupled with, a lot of times I talk with my clients about like their in basket. These are all easy answer. Like these are all, we talked yesterday about like what I think are like, there's like green zone, green problems, red problems, and then the yellow problems. And the green is like, this is here's an easy result. I can send it to you. Red is this is cancer. This is a bad problem. I have to deal with it immediately. The yellow zone ones are I have to sit down and think. I have to compare images. I have to wait, why did I do this in the first place? And they want to give it the full attention. And then those are the ones, or like a dynamic of like they had a visit with a patient that like didn't was frustrating for them, or the patient was difficult or unenjoyable or whatever. And then we avoid those. And then you have an in basket that's left over that are full of these yellow zone problems. And of course you want to avoid it because you avoided it in the first place. And so like it's sort of the nervous system that led you to avoid it in the first place is doubly when you don't do it like as soon as you can is doubly leading to now you have a whole in basket of the yellow zone problems. And of course it is going to take 5 times as long. So like this is the stuff when I work with clients about like not just like do the first try. It's like understanding why are you avoiding the stuff in the first place. So then you're like, oh my God, you're right. Like I didn't like that patient or I didn't like the answer I gave. So now you understand it. And so it's one of those things of everything magnified with like neurodivergence, I think. Of it's not just there's a lot of like busy, like there's a lot of work and it's hard and all of the things, but it's like twitchy nervous system compounded by things makes everything so exhausting because we do so much extra mental work on top of it.
Yeah, and that gets to be exhausting as we're wrapping up here. Any other thoughts that you'd like to share for all of those who are listening, just in general, who are struggling, many of whom, as we're learning, may be neurodivergent, but maybe don't even know about this or are kind of new to this?
I think slowing things down a little bit, like we tend to in life in general in this culture get on autopilot and just keep moving forward. But there is like I talk a lot about doing things in balance because we don't want to do like a lot of us can tend to be like hyper vigilant about stuff. But like So you don't want to like make everything have meaning, but we sort of need to start paying a little bit more attention to, hey, something's going on. What is my body telling me? And then what do I need to do? And also just a little bit more pausing about like in my head where I'm trying to get it to come out. But it's like, I think the stuff that we're talking about, the approaches that we are having to chronic pain, stress in life, all of these different things, like, I don't think it's the norm of how the medical profession's handling things, how people are handling things. But I do think more and more people are starting to talk about sort of how we're wired differently, or if people don't have any neurodivergence and do have chronic pain, but there's not like a tissue damage component of things. I am really excited about the future of people actually starting to address these sort of holistically, not in a non-medical form, but sort of like looking at the whole body, the nervous system, what's going on. And I do think a lot of that is involving like slowing down and listening to your body of what is my body maybe telling me. And I do think that we talk about our bodies with neurodivergence tend to be like canaries in a coal mine. And so just knowing that we're a little bit more sensitive to what's going on. And so like supporting yourself and self-care, finding support with people who really get what you're talking about. And I'm really excited to again have connected with you and at the conference connect with a lot more people who I feel are really getting it. And I'm hopeful that like more and more people start approaching things way and not like, I don't know what to do, but being curious and like sort of looking at how our sort of nervous system and everything's yeah, how everything's connected. That doesn't feel even remotely articulate, but
No,
like,
and I think that's great. There's a Dr. Mel Hauser. She's a family practice doctor from Vermont. I interviewed her a couple of years ago, and she has this thing, I think, a talk coming out about now called "Everything's Connected to Everything." She's an autistic ADHD doctor who's found out she was neurodivergent when her daughter had stereotypical autistic uh, traits, and now she has a clinic called All Brains Belong that's really helping people who cater to having staff that's often neurodivergent. And I think there's that hope. And that's actually part of why I do the podcast. I do this YouTube channel, is that until this becomes the default, that this is just standard of care, the recognition of all of this. I feel like I can't stop doing this until the message is out that it's just everybody gets this. But the most common question for the podcast and YouTube channel is, besides thank you, but do you know anybody in my area, wherever they are living, that does what you do? Do you know
yeah,
anybody who thinks like you do? Or can you see people in out of state, which I don't do out of state visits? So to wrap up, a lot of people may be really interested in trying to get ADHD coaching. Whether you mentioned working with physicians, but tell people about what you do.
yeah, gladly. Yeah. And yeah, I'm glad that your community has you. And so the name of my business it's called Beautiful Messy Self. And so my website's beautifulmessyself.com and I'm on Instagram as well. I'll work with anybody who feels like we're a good fit together. And so I do ADHD coaching, but it's trauma informed. I also mentioned, which we didn't talk about in this session, but I'm learning more and delving into the use of psychedelic facilitation for sort of healing because there is a lot of trauma, nervous system stuff. So at some point I will be offering that in Colorado. It's legal. So to a certain degree, so I like to speak on that. But I do coaching, which is the idea of coaching is like that you are your own expert. And so it's asking questions to sort of trusting the fact that you are your own expert. But a lot of times I work with physicians and I have other people who are in IT or scientists or others. They tend to be fast processing people who just something, the way that I'm speaking and the way that I talk about stuff connects with them. And I think that I do have a way of normalizing what we're talking about. And so we do a lot of whatever people need for support. And I don't do a one size fits all type of thing because everyone's different. And we do individual sessions where sometimes we're just strategizing, okay, what's going on? Sometimes they're just want an outside, they want to borrow a prefrontal cortex because they're so stuck in fight or flight, where I help them like, throw out ideas and they respond to me about like, okay, what would be most helpful for them. And
Yeah.
we do support in between with text messaging. And a lot of it is sort of just raising awareness about what's happening subconsciously and making it conscious, because once you actually as I said multiple times before, like the more we understand what we're doing and why, then we can start making change. And so when we make awareness about a lot of those subconscious thoughts or those subconscious patterns that we have that are running in the background all the time, we raise awareness to that, and then you can start interrupting it sooner, and then you can start making change. And also just like knowing that like you are not broken, like what you're doing and why you've been doing things makes sense. And so I think that's the most important part about healing, and just understanding in a safe, I'm not like your parent, I'm never going to be disappointed sort of cheerleader, but like direct psychoeducation. And also sometimes when we get there, when people feel really safe with me, questioning and poking holes in like your argument about, okay, but like how true is this? But I generally say that we don't want to start with that because people have felt shamed and attacked so their whole lives. And so we want to start with safety and micro wins and celebrations, and then work towards making real change.
Carrie, you're not that special. And for those of you who are listening, I like to share that with patients I've got a chance to chat with. And it's the second time I got in to chat with Carrie. And of course, in a way that is disarming, right? You're not broken. You're not special, meaning other people are going through similar things. And for many people, it can often seem like they're in isolation for wherever you're at in life, trying to mask, trying to power through. And you sharing your story at a minimum is validating for so many people who are watching, who are listening, and also can potentially work with you to help work on strategies. So many people say, well, okay, you described somebody struggling with chronic pain. What's the fix? And as you mentioned, it's a holistic approach. This isn't the biomedical simple approach. Yes, there are biomedical approaches of using appropriate medications and treating ADHD with stimulant medications and recognizing restless leg, recognizing sleep apnea and treating those. But usually those are part of the solution. And then it's how we frame, how we look at things, how we understand these solutions, and talking through that is what you're doing from that kind of coaching. And then what are things that you've done well? Part of often that I'm sure is involved is journaling. And often when people look through this and retrospective journaling, where they're like, and I live in a cold part of the country where, oh, well, in the summer when I had off from school and college and I was going to the gym every day and I was getting enough sleep, well, I guess it wasn't bothered. And then school started, it got cold out. And oh, so there is hope. These are things that you've had strategies that are working. And that's a chance to dive deeper. That's what this YouTube channel tries to talk about. So if you haven't listened to other episodes, you will hear stories like Carrie's and their own unique story, and everybody what's neat about helping people. No two people are the same, but likely there are people who will identify with what you're going through. And if you have identified with Carrie's story, share that in the comments, because the more people who share that, to know they're not alone. And we'll have links to Carrie, and I'm sure if she is willing to connect and start up a conversation, and if it's a good fit for you, then it's great. Everybody's got different ways of approaching things. Hopefully that'll be helpful. And then as a coach, you don't have the restrictions that I have as far as licensing across state lines and potentially internationally, I'd assume.
Yeah, absolutely. And I at least have the benefit of understanding the medical stuff. And I like feel so strongly about this that like I do like free intro calls. And sometimes it's just about exchanging ideas and hearing people's stories. And it's not, again, like I think that people feel so lonely and isolated in this, that it is really nice to just connect with other people who like have been through similar experiences. So, and I trust that it's gonna, again, work out in the universe, that I'm doing this because I miss being able to do this in my practice, but also like this is a new avenue for me to be able
Yeah,
to,
and I'm
you
so
know,
excited for you.
do
Here's a
this.
virtual high five.
Thanks.
And thanks so much for taking your time today, connecting with me again, and connecting with others.
Okay, great. Thank you so much for this and the work that you're doing.
You're welcome.